Topic of the second debate is the better choice progesterone in preterm labor, intramuscular hydroxyprogesterone versus natural micronized progesterone. It is my proud privilege and honor to invite Dr. Abha Rani Sinha. Madam is Professor of Obs and Gynae in SKMC Muzaffarpur. She is also ICOG Governing Council member for 2021 to 2022. And she has also been chairperson of Quiz Committee FOXY 2015 to 2017. Debaters for the second debate are Dr. Shakuntala Kumar and Professor Uma Pandey. Dr. Shakuntala Kumar will be speaking for intramuscular hydroxyprogesterone. She is organizing secretary of national and international conferences in 2017 and 2018. She was chairperson of Adolescent Committee AOGD 2017 to 18. At present, she is past DGF, not Secretary Vice President. We welcome you, Dr. Shakuntala Kumar. Next debater is Professor Uma Pandey. She is professor and head of the department at BHU, examiner for MRCOG examinations, and she is also fellow representative of AICOG, RCOG in 2021 to 23. So now I request Dr. Shakuntala Kumar to start her presentation. She is the first debater.
At the outset, Dr. Chitra, thank you so much for your kind introduction. Calling it a debate will be, I don't think it will be justified, because to each one, it is the availability and there are so many things for which we need a basket. We don't have to deprive the patient of treatment. When we talk about the progestogens, my previous speakers have spoken wonderfully about the recurrent pregnancy losses and the early pregnancies, and about the role of progesterone. They have highlighted very, very nicely. Now, we all also know what is preterm birth. It is all births before 37 weeks completed of gestation or fewer than 259 days. Now, we all know that preterm labor is responsible for maximal neonatal, admissions to our NICU and the morbidity and mortalities. We also know that ever since the surge of the progesterone supplementation, we have been able to prevent preterm birth and prevent all the morbidities and mortalities. Now, how does progesterone act as? By its anti-inflammatory action, which may counteract the inflammatory process. Also, it does lead to changes in the progesterone receptors, and their transcriptional activity at the tissue level is responsible. Now, we know that it is responsible for quietening the myometrium. It decreases the number of oxytocin receptors and prevents formation of gap junctions. That is how it's preventing the labor earlier than the time that is there. Now, what are the recommendations for the use of progesterone? Well, if a woman is coming with a singleton gestation with a prior history, that means if she's a high-risk lady with a prior history of spontaneous preterm birth, she should be offered progesterone supplementation starting at 16 to 24 weeks of gestation, regardless of the cervical length on the transvaginal ultrasound. This is basically to reduce the risk of recurrence. Now, vaginal progesterone will be recommended in a lady who has is incidental finding of short cervical length less than or equal to 20 millimeter before or at 24 weeks of gestation. Next, please. How? We are giving progesterone for preventing preterm birth in high-risk women, and there are several trials which have recommended the use of progesterone in reducing the risk in preterm births less than 34 weeks, in preterm births less than 37 weeks, and reducing the perinatal deaths. And it was seen that progesterone therapy significantly reduced the need for assisted ventilation, necrotizing enterocolitis, and admission to NICU. Now, when we talk about progesterone, at least less than 37 weeks of period of gestation, 5 to 6 women would require progesterone therapy with a previous spontaneous preterm birth history to prevent one preterm birth. at least 12 women would require progesterone with the previous spontaneous preterm birth to prevent one birth before 32 weeks. Now, let us talk about the molecule that I have been assigned, and that is 17 alpha hydroxyprogesterone caproate. Well, we know, friends, that we have progestogens at various levels, which are either given vaginally, as gel, as oral, as injectables, and we have multitudes of availabilities. But when we are talking about this molecule, that is 17 alpha hydroxyprogesterone caproate, this is one injectable preparation which is oil based, given 250 microgram weekly. So this was one molecule which was introduced first in 1950. So this is an age old molecule used much since time immemorial. Now it is one with a longer half-life of 7 days, with the dosage as I described, intramuscularly given, has been US FDA approved for prevention of preterm birth. Now, it has an absorption with a Tmax of 4.6 days, with a half-life of 7.8 days, extensively binds to plasma proteins, and undergoes extensive reduction, hydroxylation, and conjugation for metabolism, and is excreted in the fecal matter as well as in the urine. Now, let us look at this trial. Let us talk about this molecule per se and the various trials in which it was given. This was one trial which was done in, to establish if weekly progestogen injections with prior spontaneous preterm deliveries reduces the risk of preterm deliveries. It was a double-masked placebo-controlled trial with a singleton pregnancy starting from 16 to 20 weeks with a documented previous history of spontaneous preterm delivery. This was published in 2003. The intervention was either a progesterone or a placebo, and the primary outcome in this was delivery at less than 37 weeks. The sample size was 463 women. Next, please. Just look at the outcome that we're talking about. When we gave 70 hydroxyprogesterone caproate vis-a-vis placebo, less than 32 weeks to less than 35 weeks, less than 37 weeks, we could see significant reduction in the delivery rates compared to the placebo. Next, please. This was able to prevent neonatal complications like respiratory distress syndrome, the retinopathy of prematurity, intraventricular hemorrhage, and just look at the incidence of necrotizing enterocolitis. They were substantially reduced, and they also reduced the likelihood of admission to NICU in a substantial number of cases. Again, this is the same study that I'm quoting to. Next, please. The compliance and the safety was excellent because at least 91.5% of women received their injections at the scheduled time. Also, side effects were not major, as was highlighted by one of my earlier speakers. If given properly, the side effects found in this trial were minor, and they were similar to 70 progesterone vis-a-vis the placebo group. Again, there was another meta-analysis of 17 hydroxyprogesterone published in 1990. It was a meta-analysis of 5 trials, and the results show the reduction in rate of preterm birth, the odds ratio of 0.5 with a 95% confidence interval, 0.3 to 0.85, and a reduction in the rate of low birth weight with an odds ratio of 0.46, 95% confidence interval, 0.27 to 0.8. Next, please. Now, when we talk about 17 hydroxyprogesterone in high-risk women who are currently pregnant, this was one study that was conducted by M. Ibrahim et al. At 2010 with 50 women in their second trimester with a history of previous preterm labor. They received 250 milligram per week in their 24th week till 34th week, or the other arm received placebo. Here, the delivery at 37-week gestational week was reduced by 20% compared with the placebo group, and the neonatal delivery, the NICU stay, the birth weight of the baby, of the newborn, and the APGAR scores could be tremendously taken care of. They were found to be more favorable. 17-hydroxyprogesterone was found to be an effective drug in prevention of preterm labor in this study. These are 2 more publishing authorities which have talked about the efficacy of progesterone for prevention of preterm birth. Next, please. Now, this is one study which is very, very recent. It is basically an update which was published by Medscape in December 17, 2018. And the only preventive drug therapy in these women is found to be progesterone, given to women who are at higher risk, and it did reduce the chances of preterm birth by 1/3. Therapy would start at 16 weeks and would continue till 37 weeks of pregnancy. Now, this is one study which was withdrawn. I tried to find out the results that started, and with the recruitment happened till October 2080 with the injectable hydroxyprogesterone. This is called prolonged study, but I just could not retrieve the results because the ACOG said that probably the study was withdrawn. Next, please. Now, this is one more study published in 2019. The objective was whether mid-trimester 17 hydroxyprogesterone reduced the risk of recurrent preterm birth. And the selection criteria was women between 16 to 26 plus 6 weeks of pregnancy with history of preterm delivery in any pregnancy earlier. Here, 4 studies were included, and the reduction in the neonatal death, which was found, was to the tune of 68%. And it was found that hydroxyprogesterone caproate reduced before 32 weeks, it reduced the preterm labor to 40%, less than 35 weeks to 26%, and less than 37 weeks to 29%. Recurrent preterm birth before 37 weeks of pregnancy were reduced by the injectable, and the other morbidities and mortalities because of the preterm birth were taken care of. Next, please. This is one supplementation with the progesterone in first trimester. This study was basically to investigate whether treatment with progesterones in the first trimester of pregnancy would decrease the incidence of miscarriages. Well, not pertinent here in preterm labor, but just to tell you that here the findings provided evidence that supplementation with progesterones may reduce the incidence of recurrent miscarriages and seem to be safe for the fetus. Synthetic progesterones including weekly intramuscular 17 hydroxyprogesterone caproate, but not natural progesterone, were associated with a lower risk of recurrent miscarriage. This was published in 2016. So in women with a singleton gestation and a history of prior spontaneous preterm birth between 20 and 36 6/7 weeks of gestation, they recommended 17 hydroxyprogesterone caproate at 250 milligram intramuscularly, starting at 16 to 20 weeks until 36 weeks of gestation or delivery, and vaginal progesterone should not be considered a substitute for 17 hydroxyprogesterone in these patients. Again, this study was published in 2017. Next, please. So the debate is on whether it should be given to, to whom, which population, vaginally, intramuscularly, or orally, and for whom and at what stage. Next, please. The final few slides. This was an EPIC trial evaluating progesterones for prevention of preterm birth with international collaborative. This was to evaluate effectiveness of progesterone versus no active intervention. Here, 17 hydroxyprogesterone caproate versus oral progesterone was used. Study was published in 2017, and the conclusion was, I'll read the conclusion. Vaginal progesterone and 17 hydroxyprogesterone caproate both reduced birth before 34 weeks. Given increased underlying risk, absolute risk reduction is greater for women with a short cervix. Hence, treatment might be most useful for these women. Evidence for oral progesterone is insufficient to support its use. Shared decision making. That means, dear friends and seniors, that we have to have a decision making, sharing the conclusiveness and the compliance, cost, everything with the patient with high risk singleton pregnancies. And we should discuss an individual's risk, potential benefits, harms, and practicalities of the intervention that we are going to offer to the patient. Treatment of unselected multifetal pregnancies with a progesterone is not supported by the evidence. There are a few side effects of 17 hydroxyprogesterone. Well, we have to discontinue if we have evidence of thrombosis or thromboembolic phenomena. if there are any allergic reactions, if there is decreased glucose tolerance, fluid retention in case of specific situations like preeclampsia, epilepsy, cardiac or renal dysfunction, we have to monitor the woman very carefully. And in cases of depression, again, with the history of clinical depression, we have to discontinue in case it aggravates. To summarize, preterm birth is a major public health problem. It is a leading cause of morbidity and first and only agent to date approved for marketing by the United States Food and Drug Administration for prevention of recurrence preterm birth is progesterone. And trials of 17-hydroxyprogesterone caproate have definitely shown consistent efficacy. And friends, I must tell you that it is the cost, the compliance, and the comprehensive result that matters. That is why we have to offer a basket of choice to the patient. And that is the reason, despite of the availability of dydrogesterone and natural micronized progesterone, hydroxyprogesterone is here to stay. And it is not just a molecule which we have to offer to a niche few. If somebody is non-compliant and not able to visit our clinics, then these are those people who would require, and hydroxyprogesterone caproate is here to stay. Thank you very much.
Thank you so much, Dr. Shakuntala. Now I would request Professor Uma Pandey to give a presentation.
Yes, ma'am. Thank you. First of all, I would like to thank Dr. Ranjana Khanna ma'am and Dr. Amita Tripathi madam, and also Dr. Amrita Jaipuriar and Dr. Chitra Pandey, Dr. Abharini ma'am. Thank you for giving me this opportunity. I need to go on to the slide share. Just a second. I'm given the job of presenting micronized progesterone in preterm labor. Shakuntala ma'am has spoken very well, and she has mentioned all about what is preterm labor, why do we need to give progesterone, what could be the side effects of progesterone, and many trials. So I have brief presentation on micronized progesterone in preterm labor. We know what is preterm labor. Just I would like to say that the incidence of preterm labor is usually 7 to 11%, but if there is history of preterm birth, then it increases to 20 to 50% in the next pregnancy. Why are we bothered? Why are we bothered about preterm birth? The reason being there could be respiratory distress syndrome, bronchopulmonary dysplasia, sepsis, intraventricular hemorrhage, NEC, retinopathy of prematurity, palsy, and disabilities. So what are the risk factors when we should identify and act on? Could be history, short cervical length on ultrasound, multifetal pregnancies, advanced maternal age, infectious diseases, genetic factors, smoking, anomalies, and history of cervical conization. What is the effective treatment? Preterm birth, the most effective treatment is prediction and prevention of its risk. Just like preeclampsia, you deliver the placenta, that's the treatment. Here, preterm birth, you predict and you prevent. Perhaps you can't do more than that. So how do you predict? By scanning. How do you prevent? Trying giving progesterone. So natural micronized progesterone could be given in as vaginal suppository, vaginal gel, oral capsules. Mechanism of action has been discussed already. There is estrogen antagonism, inhibition of contraction of myometrium because of PGN, decomposes oxytocin receptors, inhibits prostaglandin synthesis and inflammation. Then dosage, this slide was also there. It has been discussed. Dosage for micronized progesterone, vaginal suppository, 100, 200, 400, gel 90, oral capsule 200 to 400. So natural progesterone is similar to that produced in corpus luteum and placenta. Okay, this I have mentioned already. When orally administered, it is metabolized in the liver and loses its potency, entailing irregular blood concentration and more frequent side effects. But if we administer it vaginally, then it will avoid first pass metabolism, will be absorbed faster, increase bioavailability, and acting on uterus in a better way, maintained in a high concentration in the serum. That's the structure, chemical structure. So I found this very interesting, that micronized progesterone, it is a natural progesterone derived from the plant source, Dioscora villosa. And what is micronization? Micronization is a process of reducing the average diameter of the particles such that the particles that are produced are only a few micrometers in level, and these plants really look beautiful. So therapy is, you are supposed to be beginning of the time supplement and published studies, they vary, but in general, we start 16 to 24 weeks for those who have history of preterm labor, whereas preterm birth, I should say, whereas 18 to 24 for those with short cervices, and as the cervical length is measured through the transvaginal ultrasound conventionally after the mid-trimester. Therapy, we usually would continue till at least 34, sometimes they continue till 36 weeks, but we will stop all this if there is rupture of membrane, or obviously if the baby delivers. That's common sense. There are a couple of studies which have shown that the micronized progesterone, this is a study was published in International Journal of Obstetrics and Gynecology Research, and which shows that it prolongs the pregnancy and therefore helps with preterm labor. Intravaginal micronized progesterone, a study published again in International Journal of Reproduction, Contraception, Obstetrics and Gynecology 2015, there is 64% reduction in the incidence of preterm labor. What does Obstetrics and Gynecology Science Review article says? That is 2017. This also emphasizes that the treatment group has longer interval from randomization to delivery. So reduction in preterm birth. Vaginally or intramuscularly published in Journal Maternal Fetal Neonatal Medicine. It also proves the same thing. And this was also published in 2013, that it reduces preterm labor. I'm not going into the studies. So we have micronized progesterone, vaginal pessaries, which have higher uterine bioavailability and few systemic side effects, although there is irritation. And Dr. Amrita mentioned very rightly, Amrita Jaipuriyar ma'am, that if she is bleeding, it will be washed out. Vaginal progesterone gel is administered through a specific applicator so that the dosage can be monitored. A suppository is inserted in the vagina with clean hand or plastic gloves, which is provided to the patient. Suppository is placed at the vaginal opening first and then pushed 2 inches above the. So these are the studies which are showing randomized controlled trial, which are showing with women with history of preterm birth. These are the number of patients here. These are a smaller number, but this study by Norman et al. 2016, 600 patients. That's quite a good number of patients. Here, Brian et al. 309, and they are saying that neonatal and childhood outcome were better. Abnormal brain injuries were less. This is the cervical length. I'm not going to the detail because everybody knows that. So progesterone for preterm birth. Cochrane review. What does Cochrane say? Cochrane says the same thing, that a woman with previous preterm birth, the progesterone reduces the risk of preterm birth before 34 weeks. It reduces the perinatal mortality and incidence of LBW, low birth weight. There is an optimum study, and it was done in 65 UK NHS hospital. That's a really big one. 65 is a lot. It is double mass placebo controlled trial, and there was only one Swedish study, hospital, 2009 to 2030. So that's a long period. They are saying that study tested the high risk of preterm labor, vaginal micronized natural progesterone from 22 to 34 gestational week would improve the outcome by lengthening the pregnancy. It will improve the neonatal outcome and improve childhood cognitive and neurosensory outcome at 2 years. This is very important. Why? Because majority of the times people are very keen, if there is preeclampsia, deliver the woman, it's fine. We'd save the mother, deliver the woman. And we think the baby has been discharged from neonatal care and gone to mother's lap and gone home, will be fine. Rarely we follow up them. Rarely we have the registers to see the neonatal outcome. Those places or countries where they have these registers, and when they follow up 2 years, 6 years, 12 years, they find out these preterm babies don't do well. So we should try not to deliver preterm baby unless and until it's really indicated. The optimum study further shall suggest that if we use progesterone, these things will have better outcome. What is the recommendation of ACOG, American College and Society for Maternal Fetal Medicine, SMFM? They recommend that women who have history of preterm birth, such as preterm labor and premature rupture of membrane, and those with short cervical length during the mid-trimester will be benefiting that. Similarly, NICE, which is from UK, and FIGO recommends use of progestogens for women at high risk of preterm birth. They induce the use of vaginal progesterone. In fact, it is recommended that women should be using vaginal progesterone because of lesser side effects and higher bioavailability and higher effect on the uterus. As Dr. Ranjana Khanna ma'am has already mentioned, that many women in our country, they may not be very keen to do that. But I think if we explain to them that this is good for your baby and this will be good for prolongation, I'm pretty sure they will do that. So how do we compare NMP and progesterone together? Hydroxyprogesterone, and this is micronized type of progesterone. And natural, I showed you the leaves, beautiful leaves. This is synthetic. Biometrial activity reduces, in general, not much. Ripening, it would prevent, we do not know, here with 17-hydroxy. A history of preterm birth in patients who have short cervix, yes, we can give it here, the short cervical length. History of preterm birth we would do, but if there is short cervical length, as per ACOG 2013, they say no. Safety, as such, we have discussed the side effects. Potentially safety signal could be there in 17-hydroxy. Increased incident gestational diabetes, no, very rare. These are the references. And this is thank you slide.
Thank you, Dr. Uma. I congratulate Dr. Uma and Dr. Shakuntala for keeping their point of view so convincingly. And now I would request our judge, Dr. Abharani Sinha, to give her opinion and her verdict.
Okay, thank you, Dr. Chitra, and thank you, Dr. Ranjana Khanna. As always, I'm a great admirer of you, and thank you so much for inviting me to be the judge for this very important session where we had two brilliant speakers, Dr. Shakuntala Kumar and Dr. Uma Pandey. Both of them have put forth their point very well. They have quoted all the recent literatures, and recently a new ECOG guidelines have come in 2021. So I'll be just mentioning that also. So I think when we have a choice of, there is no doubt that progesterones have to be given, progesterone has to be supplemented for prevention of preterm labor, both in those who have a history of preterm labor and those who are at high risk for preterm labor, that is on scanning, who show a short cervix. Again, for ART pregnancies also, I think we should use progesterone. So these are three major indications for using progesterone in the antenatal period, apart from recurrent miscarriages. Now, coming to the choice of progestogens. As said, the patient's compliance, the availability, the cost, I think all these factors, they are important. According to our setup, I think most of our patients, they don't like an injection. But on the other hand, again, vaginal progesterone is also not very well taken. So we have to balance between the two. And if we look at the guidelines, ECOG as well as Society for Fetal Maternal Medicine, they both recommend that 17-hydroxyprogesterone caproate can be used, whereas FIGO and NICE, they recommend the use of vaginal progesterones, micronized progesterones for use in prevention of preterm labor. So what we have to have a path according to the indication, according to the choice. Like if it is a case with a short cervix, I think definitely vaginal micronized progesterone should be given. If she has only a history of recurrent preterm labor where we have not already scanned the patient or we are just giving it for preventive, depending on her history, I think we can go for an injectable progesterone. So injectable progesterone is also not out. As I think Dr. Shakuntala had mentioned about the prolonged study. I think I could see the results in one of these studies where they had withdrawn the study in between because they found that it was not effective. Like when they compared it with placebo, they did not find it very effective in terms of reduction in the rates of preterm labor or in the terms of fetal benefit. But still, after that also ACOG 2021 also again comes with that same point that you have to make a guided decision. You can use 17-hydroxyprogesterone caproate or you can use vaginal micronized progesterone. So we can use either of them. And we have a very learned expert with us, Dr. Ranjana Khanna. I think she'll come up with the final verdict. And thank you, Dr. Amita Tripathi, Dr. Amrita Jaipuriyar, and Dr. Chitra Pandey Thank you for inviting me. So over to Dr. Ranjana Khanna to give the final verdict.
Okay. Actually, I feel that many a time when a patient comes to us and she is having premature labor pains, then I prefer to give a shot of 17-alpha hydroxyprogesterone caprate, because I am sure that I have given it. See, if I prescribe a certain drug, unless the patient gets admitted and then we give her vaginal progesterone, NMP, that's fine. But if she has come to me, if she is not hypertensive, if she is not, say, preeclamptic, if she doesn't have any renal problems, if her BP is all right, if her cholesterol is all right, then I would like to give a shot of 17-alpha hydroxyprogesterone, because I'm sure that the patient, it's inside the patient and the effect will be there for 1 week. So that's one way I feel. And another thing is that it is also rather economical to the patient's pocket, because for 1 week, she's spending only that much amount of money, 300 or whatever. But in the other case, vaginal is much safer. NMP is much safer. In fact, I was very surprised to read that the Australian guidelines are saying that even oral NMP is a category A drug in pregnancy. We don't get category A drugs, all of them are grouped in category B. But NMP, they are saying, is orally, it is category A drug because it has been tried in so many pregnant patients. So that is because it is a natural product, and vaginally it will give a very good response. And I feel that in cases of patients with short cervix, there the role is only there of vaginal NMP. Then, we should not even try 17. Maybe we can combine it. We can give a shot of that to begin with. But then we have to give vaginal, because if the cervix is short, so we have only two options, either a cerclage or vaginal progesterone. And of course, we prefer vaginal progesterone nowadays. In our olden times, we used to immediately go ahead with the cerclage. But now we have found that vaginal progesterone is very, very effective. So we go ahead with that. So I think the point is that if the patient does not have any comorbidities, then it is as good to give 17-alpha as vaginal NMP if the cervix is not short. But if the cervix is short, then NMP, vaginal NMP is the definite ruler and the definite answer. So we can have a choice with 17-hydroxyprogesterone. And I must congratulate Shakuntala, because I gave her, I think, the toughest topic out of the 4. And she took it up wonderfully. Yes. And so kudos to you for taking up this topic, because it was, relatively we have a lot of material on NMP, but fishing out so much matter of 17-alpha hydroxy. But I am convinced about that. And this is my take. So in a nutshell, if the cervix is short, please go ahead with vaginal NMP. But otherwise, we have a choice between intramuscular 17 OHP or NMP. What do you say, Dr. Abha?
Yes, Dr. Ranjana, I totally agree with you. And there is still a role of 17-hydroxyprogesterone caprate, because the compliance is very important.
Compliance is
very
good.
Because the patient who has a previous preterm birth, she is very keen to have a good outcome in this pregnancy. So here and many of our patients, they ask for injectables. There are patients who ask for injectables. Yeah.
Because the elders in the family are not convinced unless injection lagao.
So, and weekly injections.
They want ki injection lagao. Arey, कोई ट्रीटमेंट ही नहीं हुआ, इंजेक्शन तो लगा ही नहीं, पेशेंट तो गया था, उसको तकलीफ थी, इंजेक्शन तो लगाया ही नहीं, गोलियां रखने को दे दी और घर भेज दिया.
And we have strong recommendations for 2 very important bodies like ECOG and Society of Fetal and Maternal Medicine. So I think still it has a place, but I think this vaginal micronized progesterone, it has got more compliance in good groups, like in educated patients. In educated patients, it has got a good compliance. So I think vis-a-vis, I think both
But
of the
I think the decision should be made with the cervical.
yes, individualized. Yeah,
Yes.
cervical length is one very important point
So-
that you said.
Huh. If the cervix is small, short, so immediately go in for vaginal.
Vaginal, sure, sure. Convince your patient. Convince your patient and ask them to take it vaginally.
Yes.
And both the speakers were brilliant, Dr.
Very
Shakuntala
good.
and Dr. Uma Pandey.
Dr.
Really
Uma Pandey, you
hats
put
off
across
to
your
you.
points also
Hats
very well.
Hats off to both of you. Thank you so much. Hats off to you.
Okay, thank you.
Thank you, Dr. Ranjana Khanna ma'am and Abharani ma'am for
Ultimately, we have to leave the decision on patient. That is
Exactly.
But we have to offer.
so many times. Yeah.
I mean, this is the menu. Now you take. Now we have to offer.
Definitely.
Thank you, ma'am, for your expert opinion and valuable advice. And I congratulate all the debaters for such an interesting and thought-provoking session.